with an intensive, you can get through so much trauma work so quickly that your clients aren't traumatized anymore. And so that cuts out a lot of the need for the stabilization work that may have been necessary for some clients if you're doing hour per week therapy. That's one of the reasons that I see intensives becoming a standard of care.
Good morning or afternoon, depending on where you are. Ricky Greenwald, welcome to the Art and Science of EMDR, and thank you for joining us.
Thank you for having me.
Yeah, so Ricky, we're talking about EMDR intensives today, and EMDR intensives seems to be very trendy these days. A lot of people are doing it, a lot of people are learning it, and I think that you've been doing EMDR intensives maybe longer than anyone else or somewhere in that range.
I was one of the early ones, along with Katie O'Shea, Sandra Paulson.
How
Yeah,
long have you been doing that EMDR intensive?
I did my first ones quite a long time ago, but I really started doing it, I'm thinking about 13, 14 years ago. A couple of things happened. One is that I was traveling so much that I couldn't really tell a client, I'll see you next Tuesday at 10, because, I'm going to be in Ohio next Tuesday at 10. So it was a way to still do some therapy. So it started out as a convenience, sort of as a practical matter, but I came to prefer it. As you mentioned that it's trendy, I don't see it that way. I think it's an emerging standard of care, and it looks trendy now because it's just starting to emerge, but I think it's going to continue.
Yeah, emerging standard of care. Can you speak of that a little bit?
Yeah, I think that people are going to recognize intensives as actually a better way to get therapy done in many circumstances. And especially once insurance companies start covering it, it will just be the way that many people get their therapy done. I mean, think about, right, you take your car to the shop and the mechanic says, hey, you're driving around on bald tires. That's not really great. Tell you what, bring in your car once a week. Every week I'll change a tire. And in a few weeks, you'll be good. Right. But that's what we do with our therapy clients. We say, wow, you got really serious problems. You're at risk of losing your family. You're at risk of losing your job. You're suffering in this way or that way. Tell you what, you come in once a week for 50 minutes. In 6 months or a year, you'll be good. So it's the advent of EMDR that has enabled us to be more like the car mechanic, right? Because before we had methods like this, the incremental therapy made a lot of sense. You do a little work, you work it out in your life, you come back, but what I think many of us are finding is that the bulk of the work gets done with the trauma healing, and that's what changes so much else. And there's nothing about trauma healing that requires getting chopped up into 50-minute blocks. And so, you can work with a client for a bunch of hours a day for several days. You get a year's worth of work done. Now, some clients are going to waltz away and live their life. Others are going to need, weekly therapy for a while, because it's like any major life change, right? Somebody dies, you get divorced, you become disabled. Any major life change, you're going to say, who am I now and how do I operate in the world, right? So sometimes even after a very successful intensive, you're still going to want to work with a therapist for a while and reorient yourself to who you are now and how you work. Yeah, you can get a lot done in a very short period of time. And why not get the results of therapy this week instead of driving around on bald tires for the next 6 months?
Yeah, I like that analogy. That makes a lot of sense. And I'm wondering, so you started doing this work out of a need, but then now there's more even research about the efficacy of intensives in general and EMDR intensives in particular. So I'm wondering if you can talk about that.
Sure. Oh, of course, I can't remember her name. Somebody whose name I'll remember as soon as we're done.
Sandra
Did it?
Paulson, just kidding, just kidding.
No. No, it's a Dutch researcher. Did a really nice randomized.
Are they young?
No, it wasn't EMDR, but she
Oh,
did a nice randomized comparison of trauma-focused CBT for adults, like prolonged exposure, basically intensive versus weekly versus waitlist versus supportive. And basically, she found that the trauma-focused therapy was twice as effective as supportive therapy in eliminating the PTSD diagnosis, and the intensive and weekly were equally effective in eliminating the PTSD diagnosis. That was the highest quality study in terms of research design. De Jong's team has done a bunch of research. We've published a couple of studies. What we're basically finding is you're getting the same results, except you're getting them in a week instead of a year. But in terms of the published results on EMDR and what you would hope for, you're getting the same results. You're getting it very quickly. Our research, we've got a dropout rate of, about 5%, which is low. And it makes sense because, if you do hour per week therapy, there are a lot of opportunities for people to drop out before they finish the job. You do the stabilization work, and a lot of people are going to say, I'm good now, thank you very much. And they'll never do their trauma healing, which of course means that they don't get necessarily the profound or lasting results that we're hoping for. Well, people have life circumstances, especially if they're driving around on bald tires. They have a lot of life circumstances. And so they can get arrested, they can get injured, they can get a job in Florida, things happen. Whereas with an intensive, people block out time, they arrange childcare, they go in and they do it. And there's still occasionally somebody who says, hey, this just isn't good for me. That's more of a screening issue than anything else. And, we do an hour-long screening by Zoom just to make sure that by the
it's the
time you
right fit.
come, it's we have a pretty good chance that we're going to be successful. Yeah.
Right. So I'm curious, so what would be, let's say, exclusion criteria for a person to participate in
Mhm.
EMDR intensive?
Okay. Well, basically, and every therapist does this, right? But normally the screening is done in the first couple of hours of your hour per week therapy, right? Come in, we meet, we talk, we check each other out. And
Right.
sometimes you work together and sometimes you make a referral. Sometimes the client just doesn't like you, and that's fine, right? So we just have to do that ahead of time. In terms of who we would screen out, we would screen out somebody who we don't think is going to be safe because we're not a residential program. We don't have somebody on you. So if you're very unstable and really at risk of getting hurt or hurting somebody, we can't we can't monitor and support you around the clock for that. So that's not the right setting. If somebody's on the edge and they bring a companion with them to help them stay stable, yeah, we'll do that. So that's one issue. Another is a high level of dissociation. And even then, it depends on where they are in their treatment. So somebody can have dissociative identity disorder, and if they've gone through enough steps in their treatment to where they're ready to do this, yeah, we can do it in an intensive. But if they haven't gone through those steps, we haven't found an intensive to be appropriate because they're not going to be doing so much EMDR. They're going to be frustrated. It's just not, we want to get. That being said, we don't cherry pick, our typical client, especially in our grant funded programs, complex PTSD. So we do work with very distressed clients. Not only we work with a range, but yeah, if we think that they're really not going to be able to do the EMDR, or if they're so unstable that it's risky, then those are the people that we tend to say, not right now. There's some things we want to see before you do an intensive.
Yeah, I'm curious about stability. Ade Young, who's done many, many studies with, borderline personality disorders and people with, with high level of dissociation, doesn't emphasize the need necessarily for stabilization. And just to make things clear, a lot of his research was done in an inpatient setting.
Mhm.
So I'm curious about what is the setting and what are your thoughts about Ade Young's research about not necessarily maybe caring about stabilization the way most of us do. I think that at least the ones who are trained in the United
Okay. I read one of his studies a few years ago. They had only a 70% success rate. Another study I read more recently, the success rate was higher. Our success rate is in the 90s. So his current stuff, it may be higher. So I'm not sure. So one thing is I'm not sure how to evaluate. They're also mixing prolonged exposure with the EMDR. So it's kind of hard for me to evaluate exactly what they're doing and how well they're doing. Are they overcoming dissociation, or are those the clients they're losing? I don't know.
Yeah.
So
I,
it's
I'm
hard for
curious.
it's hard for me to speak to their work,
Yeah.
but in terms of stabilization, how much preparation do clients need?
Yeah.
I think he's taken an extreme position on that. And I mean, he wrote a paper on it with some very heavy hitters in the trauma field. And what they said is, hey, look, we got all these laboratory studies where all that preparation wasn't required. Yeah, but those are laboratory studies where you're screening people out. You're it's
You're
very
carefully
different.
picking your
It's
subject.
very and some, some of those carefully picked research participants were highly distressed. So, but all the same, just because you got, a 15% dropout rate and an 80% success rate in your research study doesn't mean that you can just disregard clients' needs in clinical practice or client safety in clinical practice. And at the same time, so I think they're taking an extreme position based on primarily laboratory research, whereas in clinical practice, if you charge ahead with EMDR and clients are not stable enough, you're putting them at risk. So the great thing about intensives is you can kind of split the difference, because many clients where you might need to do a lot of stabilization work ahead of EMDR, in an intensive, you don't have to, because it's not that they can't handle the EMDR, it's that they maybe can't handle the aftermath. And with an intensive, I mean, you want to know the best stabilization strategy? Not being traumatized anymore,
Yeah, that
right?
that works pretty well.
Yeah. And so if you can, with an intensive, you can get through so much trauma work so quickly that your clients aren't traumatized anymore. And so that cuts out a lot of the need for the stabilization work that may have been necessary for some clients if you're doing hour per week therapy. That's one of the reasons that I see intensives becoming a standard of care, because it cuts out a lot of treatment hours that you would need, at least in some cases, if you were doing hour per week.
Yeah, and I think that once you're doing an extended session, it's just so much more efficient, just because in a 50-minute session you have to check in with the client and then you have to close the session, right? You
Right,
have to make sure
right.
that they're regulated before they leave your office,
Yeah,
and that leaves you very little time to actually do the reprocessing work.
right. You're not only cutting out some of the stabilization work that you might need to do an hour per week, but as you're saying hello and goodbye, takes what, a third of a session?
Right.
Right? I mean, between checking in, putting out fires, right, all that stuff, and then on the other end, helping clients regain composure. Yeah, it's about a third of every session. So you do an intensive, it's like binge watching a season of a TV show. There's no recaps, there's no ads, right? It's just all progress.
I don't know if I like this analogy as I do the first one, but the binge watching is not necessarily a positive connotation, but I get your point, and
Mm.
point
It's
taken.
it's it's efficient. You're
Yeah,
cutting out stuff that you would need to do, that's appropriate to do, that's necessary to do in hour per week therapy.
yeah. So Ricky, I'm wondering if we can get a little bit into the mechanics of what does it look like to do intensive? What does intensive? So you mentioned the screening. You're doing our screening Zoom. You want to make sure that you have, the
Yeah.
appropriate client, and then what?
Okay. So in our screening, now we're a group, I run a nonprofit organization, Trauma Institute and Child Trauma Institute. we have, I don't know, about 10 therapists right now. And so in our intake screening thing, we're not only figure out, are you safe and appropriate for an intensive? Are you likely to be able to do it and get something done? Also, how many days do we think it's going to take? And which of our therapists do we think are the best match for you? So those are the kinds of things we're doing in the screening. Then we schedule it. I know, there's probably about 100 credentialed, EMDRIA approved EMDR training providers just in United States and Canada. Maybe over 100 by now. And we're all teaching some version of the standard protocol, which I have learned is not exactly standard, but pretty close, right?
Yeah.
But the standard protocol really applies to phase 4 and 5 and 6, right? This part, the, reprocessing, the installation, the body scan, that's the most standardized part. We have a sort of a manualized treatment approach also for phases 1 and 2, where we have a scripted, really step by step from hello all the way through goodbye. And so our therapists all learn this approach. And so we're getting done, rapport building, expectations, motivational work if that's needed. What are the goals here? What kind of life are you trying to be living? History taking, absolutely including the trauma and loss stuff that we expect to be working with, case formulation, treatment plan. Our newer therapists get that done by lunchtime of the first day. Our more experienced therapists, faster. If a client needs attachment work, there's a couple of different methods we might use for that, sort of as resource building in anticipation of the EMDR. I love Phil Manfield's work. We use his dyadic resourcing. We use an attachment visualization that I developed. So typically by lunchtime, give or take, we're starting the EMDR work. And again, I mean, different people do it different ways. We work in chronological order. And we just work our way through the client's list of the worst things that happen to them.
Yeah, so I'm curious, you mentioned
Yeah.
the standard protocol is mostly phases 4 through 6,
Yeah.
reprocessing, and then you mentioned 1 and 2. What happens in phase 3? Phase 3, the way I see it is
Oh,
also
right. Yeah,
standardized.
that's pretty much standardized too. Sorry, I forgot about that.
Okay, so
Yeah.
3, 4, 5, and 6
Yeah.
are pretty standard.
Yeah.
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 So I'm going back to stabilization because, again, I know I shared with you before we started recording that I had what some people consider mini intensives, or I don't know, maybe micro intensives, just a few hours. And I'm wondering about the need to stabilize when you're working in an intensive format. If there's how do you approach that? Because the client is not leaving your office after 50 minutes. So can you, while you're processing, what is going on with, with stabilization and resourcing?
I don't understand the question. I mean, while you're processing, while you're doing EMDR, you're doing EMDR.
Right, you're doing MDR, but let's say the client is less stable than like the client, let's say they're out of the window of tolerance.
Mm-hmm.
Are you bringing them back, or do you keep reprocessing?
Well, if they're out of the window of tolerance, they're probably not getting processing done.
Yeah,
So in that way, doing this in an intensive format is no different than doing it in the hour per week format. If a client's out of their window of tolerance, other stuff is happening and they're not getting processing done. So you want to bring them back.
yeah.
Yeah.
Okay, that makes sense. And then I'm wondering, so the phases we didn't talk about are 7 and 8.
Let me actually
Yeah.
finish answering your question.
Okay.
Okay. So I should mention that in addition to EMDR, we're using a lot of flash as well as progressive counting, which is another method that's sort of competitive with EMDR in several comparison studies. Anyway, so we're using a lot of EMDR, but these other methods as well. And we really try to work our way through the client's list of worst things. And then for the last, say, half day of the intensive, whether we finish treating all the trauma memories or not, for the last half day, give or take, last couple of hours, we shift to preparing clients to return to their lives. And so that's when we might work on stabilization skills if those seem to be necessary, practical strategies, etc. Okay.
Okay, excellent. That answered my
Just to
question.
finish answering like what happens in an intensive,
Yeah.
and then we schedule a follow-up to really check in and see if any further treatment is needed or maybe even just guidance or whatever. Yeah.
Right. I'm curious about phases 7 and 8.
Okay.
So we close with the client. Let's say I know that a therapist in where I live in Denver who has people coming from out of town to do work with her and sometimes for 4 or 5 days.
Mhm.
And then what do you do next week if they're going back to their state and
Right.
we are licensed in our state?
Mhm.
How do you address that? Or do you make sure that they have a follow-up appointment with a local therapist? How does all that work?
Again, the way we do it, and I'll just answer the way we do it. I used to just be able to say this is how it's done because we were the main ones doing it. But I don't know if you're aware, but there were many years that I'd give a workshop at the EMDRIA conference on intensives, an hour and a half workshop, and there'd be 2, 3, 400 people in the room and everybody asking questions. And at this point, there are hundreds of people doing intensives and several other people teaching different things about it. So my answer is how we do it, because I know there's so many different ways people are doing it now.
Right.
Um, okay, so for one thing, in our screening, we're already anticipating this. And we identify some prospective clients who we feel are so stable that we don't have to worry about their stability at follow-up. They either already have support in place or they just don't need it. They're fine. Other clients, um, there are many clients that we feel, yeah, you're suitable for an intensive, but we want you to have an existing relationship with your own therapist. So when you found a therapist you like and you've been working with them for 6 weeks, then we'll come back and we'll schedule you. Right. And so because I can't hold your hand next week, because for one thing, I'm not licensed in your state. And for another thing, I got another intensive next week, or in my case, maybe I'm training or whatever. Right. And so this is a limitation of intensives as they're currently practiced, is that we can do some. I mean, we do follow up with our clients and we check in with them and we might make a referral or recommend additional days or whatever. But in our screening and preparation, we have to line this up with the understanding that we're not going to be there for our clients in the long run when insurance companies start covering intensives. I think a hybrid model is going to be superior to what we're doing now, where therapists will have an hour per week kind of practice for 1 or 2 weeks per month, where they're seeing clients for the 50-minute sessions. And then they fit clients into one of their intensive slots when they feel like it's a good time and when they have the time. And then they're able to follow up those clients in their other weeks when they have those hour per week. I think that's going to be superior, kind of a hybrid model that's more locally based. But for the most part, we're not there yet.
Yeah, so this is the second time that you mentioned when insurance companies, you didn't say if, it's a pretty optimistic view. So how do you see that unfolding, insurance companies covering intensive? I know probably need more research for that, but what are your thoughts? I noticed that you said when and not if a couple
Right.
of times.
When, well, there's one of the largest insurance companies in the country has been working with us for several years now, and they make referrals to us for certain kinds of cases. Other insurance companies have covered an intensive on a case by case basis. There's a local Massachusetts major insurance company. We're playing telephone tag about talking about doing a pilot project with them. So insurance companies are already kind of tangentially participating even now. Most people are getting intensives either through private pay or through a grant-funded program. I know E.C. Hurley was providing intensives for veterans through government-funded programs. We're providing intensives in Western Massachusetts for a grant-funded program for victims of crime. We got a program in Wilmington, North Carolina, also grant-funded for school students and their families. We got something starting next year in Rochester, New York for court-involved adults and free intensives to reduce recidivism. It's going to be funded by the county mainly. So really what it's going to take is more research, how to go from experimental to well-established. And the research is coming out. We're doing it. De Jong's doing a ton of it. Other people are doing it too. Now, another issue with insurance, and this is an issue, is the return on investment. So we know that it's called, I think, the medical offset of mental health dollars, that for every dollar you spend in psychotherapy, ultimately you're going to save $6 in overall medical costs. That's old research. It might be different by now, but we know that psychotherapy pays for itself, and certainly effective psychotherapy pays for itself even better. However, it takes an average of 5 years for an insurance company to get the return on their investment. And people change insurance companies on an average of every 3 years. So the math doesn't work right now. So insurance companies, in my opinion, are going to start doing this with the high-end clients, the clients at risk of residential placement, where they're going to be spending that money in the short term. So they're going to realize the return on their investment. If our country made any sense and we had single payer healthcare, then we'd have a long-term investment in our citizens, and intensives would get covered that much sooner. But I do
If
think
our country made sense, that's I think a topic for another conversation.
right.
But I'm wondering, Ricky, about you mentioned effective psychotherapy, right? Pays for
Yeah.
itself. And how do you measure the efficacy? How do you compare?
So there's a debate about whether any psychotherapy is better than any other. And there's one body of research that says it's all the same. The common factors, people tend to like that body of research. And there's another body of research that says, actually, the trauma-specific treatments treat trauma better than the generic treatments do. And then a nice meta-analysis came out a couple of years ago by Mavrin Azuli and colleagues, I think in 2021 or 22, and they found that EMDR was more cost effective than the other leading brands. And I'm going to make up numbers here. I don't know if these are the correct numbers or not, but basically it would cost you $2,000 to get the job done with exposure, or $1,200 with EMDR. Those numbers might be wrong. I'm not sure if I'm recalling the findings exactly,
Yeah.
but something like that. So the way I read the research, yeah, some therapies are more effective than others, but I know that other people read the research differently. So it is an ongoing debate.
Yeah. Okay. Thank you for that. So Ricky Greenwald, thank you so much for your time and knowledge with us today.
All right. Thank you so much for inviting me.
Of course.